Uh, Thank you for inviting me and allowing me to select this topic, because Jai had given me another topic, and I thought that this is something close to my heart for the last several years. And also I'm happy to see Jagdish Hiremath here, because he has been a very integral part of this effort that we have been trying to take against all odds. So let's look first at the topic, and then we look at what we can do in the community, specifically in our Indian setup. So sudden death is a natural death, unexpected, in a patient who may or may not have known heart disease. Even if the person has a known heart disease, is not expected to die suddenly. So within 1 hour of acute onset of symptoms as a collapse, then you call it as a sudden death. We know about sudden deaths, crib deaths, sudden infant death syndrome, but that's a very minor number of all the sudden deaths. The commonest age group for sudden death is the middle age, not the very elderly. So between 45 and 65 typically in the Indian context. If we look at cardiac deaths and how many of those are sudden, and then see at different ages, the younger a person is and has a cardiac death, the more likely is to be sudden. For example, in a person who's 25 years old or in that age group, 75% of cardiac deaths will be sudden. As you grow older, the percentage of sudden death in the older population is about 50%. In people who are more than 35 years of age, the incidence of sudden death is about 1 to 2 per 1,000 per year. Now, this can vary in different parts of the world. In India, we don't have full population records, but when we extrapolate from whatever restricted figures, data we have, and we extrapolate also from the fact that how much is heart disease more common in India, then we come to around 1.5 to 2 million sudden deaths in India. That means about 15 lakh to 20 lakh people die suddenly in India every year. In the younger population, less than 35, it is extremely uncommon. It's just 1 to 8 per lakh. In people less than 65 years of age, there's quite a male preponderance. 4:1 is male to female ratio, but in older people, the female incidence rises and the ratio almost tends to equalize the older you get. People are getting more and more athletic, running more and more, exercising more and more, and marathons. I think India has something like 3,000 marathons a year. So, yes, you run a marathon, but do it for your own kick. Generally, marathoners live less than people who exercise sensibly and moderately. So the incidence of sudden death among athletes is almost 3 times compared to that of non-athletes. And in young athletes, the ratio of male to female is 10:1. If one of your parents has a sudden death, you have double the chance of having sudden death. If you look at the underlying causes that lead to sudden death, and if we go from age, so in children and young adults, there are more electrical problems, what we call channelopathies. So either catecholaminergic ventricular tachycardia or long QT syndrome. These are the commoner channelopathies. There are other uncommon ones. And then you have structural problems, the typical cardiomyopathies. Hypertrophic cardiomyopathy, arrhythmogenic cardiomyopathy. We no longer use the term ARVC. We call it arrhythmogenic cardiomyopathy of the right ventricle, left ventricle, or biventricular types. But even this is quite variable in different parts of the world. For example, in Western countries, in younger people, about 10 to 15% of all sudden deaths are cardiomyopathies, when Japan is 30 to 35%. Whereas the commonest underlying substrate after middle age is coronary heart disease, which is around 75% in the Western hemisphere, but just around 50% in Japan. So there are regional variations. Having said that, the major chunk is acute and chronic coronary artery disease, followed by cardiomyopathies of various types, and the least common are channelopathies as underlying causes of sudden death. And what is the final event that leads to sudden death is most commonly a ventricular arrhythmia, and very less commonly primarily a bradycardia. What is important to recognize, and this is from a classical Holter published many years ago by Mark Josephson, is that this is a person who died when the Holter was applied and the data was retrieved, that within 10 minutes you go from sinus rhythm to relatively organized ventricular tachycardia to polymorphic VT to asystole. Now why it's important is that in hospital cardiac arrest or in ICCU cardiac arrest, typically our witness cardiac arrests are ventricular arrhythmia, where prompt defibrillation, the ICU will at least immediately revive more than 90% of people. But most out of hospital cardiac deaths, if not picked up immediately or not acted upon immediately, will soon result in asystole. So the chance of reviving a ventricular fibrillation in the ICU is more than 90%. A chance of reviving someone who has gone into asystole is zero, nearly zero. So that is why one should recognize and act on cardiac arrest as fast as possible. And why is it important? You will say, but most cardiac arrests will occur in the ICU, isn't it? Wrong. Yes, those who are in the ICU, those who've had acute MI, those who've had heart failure and are admitted, they are high risk. They have almost 25-30% chance of sudden death in a year. But if we look at who of all sudden deaths, for example, we say in India 15 lakh people die suddenly every year. A majority, 90% of them, that means about 13 or 14 lakhs will be in the general population. They will not be patients who are identified at high risk or patients who are in the ICU. In fact, 80% of cardiac arrests are out of hospital cardiac arrests. So majority of cardiac arrests are out of hospital in people who are not identifiable at high risk, because this denominator is so huge. That most deaths will occur there. And hence, early recognition and early action is what the community approach should be. It's not doctors, it's not paramedics. It's the lay people who need to be involved to make a difference in cardiac arrest in a meaningful manner. This Swedish study, and Sweden, Scandinavian countries have one of the best records in resuscitating cardiac arrest. As a nation, of course, as isolated pockets, you have Seattle, which has one of the highest revival in sudden death, or you have Tokyo. But as a nations, it is a Scandinavian nations. If you look here, the time from cardiac arrest to the first defibrillation, if the time is less than 2 minutes, you have a 50% survival. But when the time is 10 minutes or more, it goes down to 10%. To roughly every minute wasted without at least CPR, every minute wasted reduces the chance of survival by 10%. And this is a typical scenario, or used to be the typical scenario in India. This was a slide I've shown several times sent by Rabin Chakrabarti from Kolkata, but it's true for most parts of India. But the scene is changing. So this man is dead suddenly, people are watching. The thing is, now we say recognize cardiac arrest and act on it. And the chain of survival in cardiac arrest has changed. When I was a medical student, for cardiac arrest, it used to be the hospital which was thought to be most important. But now it's the person on the spot, the bystander, who's the most important. So we say call, push, and shock. If you recognize cardiac arrest, call for help. Push means start cardiac massage. And shock means look for the closest defibrillator. You are the hospital. The hospital or paramedic or ambulance has to come to you, rather than you taking a cardiac arrest victim to hospital. And if we look at Seattle, which has one of the best survival rates, in fact, citizens of Seattle take it upon as a pride to take out as an insult if somebody dies of cardiac arrest without attempts to revive. What did they find? That if you start CPR within 4 minutes and get access to defibrillator within a few minutes, almost 50% survival. But if you do not start cardiac massage, the word massage again is a little distinct, because you see in Hindi movies also, people are actually just massaging the chest. So it should rather be called compression, chest compression. If you don't start chest compression within 10 minutes, then whatever you do after that, the chance of survival is zero. I said Scandinavia has one of the best outcomes. If you look at this, it's amazing. If you look at this study from Stockholm, when you have public access AEDs, so AEDs have to be at railway stations, malls, crowded places, big housing societies, public access AEDs, police stations, then they had 70% survival, 70% survival. And a systematic review of many different studies showed that in places where they had public access defibrillators, overall there is 40% survival of cardiac arrest, which is a big number, Because in India, I don't have figures, but I can confidently say that it is less than 0.5%. And therefore, what we should be doing as a community, and we started this effort several years ago in a small way, and this movement is growing. It's the cardiologists, physicians, anesthesiologists, even doctors from all other specialties in different parts of the country who are coming together to make people move, at least have a simple training, which is less than 1 hour. Simple training is enough for people to administer chest compressions. And those who are interested, especially college students, go for little more training and become trainers themselves. That's the way we must move the lay bystanders or lay people from being aware to being trainers, especially the younger generation. So, with this in mind, in 2017, we started iCare, Cardiac Arrest Resuscitation for Everyone, which is now called the Revive Heart Foundation. The Anesthesia Association, others in other parts of the country also have been doing this work. But unless we all join hands, I don't think it will come to anything meaningful. Several of my colleagues said, it's a good thing that you're doing it. We will cheer you if anything comes out of it. And actually, we witnessed 3 sudden deaths amongst doctors, all in their 40s within 3 months. And that's when we thought, let's do something at least. Okay, we may fail, but at least let's do something. We realized that whatever we do, we can reach audiences like this, we can teach in schools and colleges, but people have to be motivated. When we used to have programs in health clubs, only the 60 plus would attend. Youngsters would not. And we realized that to increase the reach, we need people, we need to use social media, use celebrities, use sports person. Luckily, many of them were forthcoming, cricketers, tennis players, badminton players, Olympians, and our colleagues, doctor colleagues who were there, doctors in one way or the other helped us get. And so when, for example, this same video, when we made it, we could reach out to maximum 20-30,000 people. One video made by one of the film stars for us reached in one day 2 million people. And so far this video has been seen by more than 5 million people. So I think, so important thing is that there was no formal training for cardiac arrest for us as medical students. Now there is. We were taught to check the pulse. It's wrong. Now it's conclusively proved it's wrong to check the pulse to diagnose cardiac arrest, because if someone really has a cardiac arrest, you might be feeling your own pulse. And if someone doesn't have a cardiac arrest and it's a feeble, vagal episode, you may not check the pulse. So, you have to look at whether the patient is conscious or not and whether the person is breathing or not. Because except cardiac arrest, there is no other condition which causes these two. All other causes of unconsciousness, whether it is a hypoglycemia where we recover, or a stroke, or an epileptic attack, after the first 15 seconds you will start breathing. Not the gasping breathing, but you'll start breathing. So that's what we call recognize. That means look, tap, no response. Look and tap. Look for breathing, no breathing, you diagnose cardiac arrest. So it's easy to teach the lay public to recognize cardiac arrest.
तो CPR
The
देना
fears when we started, the
हमारे
fear
देश
was,
में
the
रोज
skepticism
कितनी
was, who in
cardiac
India wants to
arrest
get
से
involved?
जाती
If there's a road
CPR
accident,
से अगर
at the most
इनमें से
somebody
कुछ
will call
जाने
the
भी
police
बच
but drive away. Nobody
और
wants
क्या
to get
चाहिए?
caught into that
इससे बड़ा पुण्य
mess.
क्या हो सकता है?
Now we have the Good Samaritan Act in India also. So if you were to try to revive somebody for cardiac arrest, you cannot be penalized because anyway that person would be dead. In fact, that was the major reason to get the police trained. So the police is your friend rather than the police coming in your way if you try to help someone. So we started in 2017 and so far we have trained about 3.5 lakh people in CPR with more than 1,000 training workshops and installed several public access AEDs. So this is an example of the public access AEDs installed in the suburbs of Mumbai. And also one of our colleagues, Dr. Akshay Mehta, along with the road stations of Mumbai. You see the I was today also disappointed when I saw AEDs at the Mumbai and the Ahmedabad airport which said to be used by trained personnel only. That defeats the purpose. And I called up the superintendent, hopefully they'll remove it. And AED is supposed to be idiot proof. It's supposed to be used by anybody. That if you say trained personnel, then most of the time there won't be a trained person to use the AED. In fact, Dr. Jagdish Hiremat and his group in Pune have installed, I think, Jagdish, more than 20 or 25 public access AEDs. These are some examples. So the first person who survived as a result of our small effort, who was revived by somebody trained by us for CPR, who not only used chest compression, but also got an AED from a close by, it was close to Otters Club at the Bandra Carter Road. In fact, when we retrieved later on the AED information, we found that actually the patient had gone into polymorphic VT, VF. This is the first shock where he came back to normal rhythm, but soon had bradycardia, again developed VF. He gave a second shock and the patient survived. In fact, the person who revived him, Samir Farishta, was himself getting panicky. He said after 2 shocks if he doesn't revive. And there's a policeman standing there who said, why are you doing this? Let's take him to Holy Family Hospital. So he was saying if he doesn't survive, I might be in trouble. But this patient is alive and well now. This was another person while playing tennis. He had a cardiac arrest. He was revived. There was another doctor colleague, an ENT surgeon who was also playing tennis who revived him. And they used an AED which was in the gymkhana. In fact, all health clubs, all gymkhanas, again, they are high risk areas for cardiac arrest. Dr. Ajit Desai, one of our colleagues, has himself saved 2 people out of hospital with cardiac arrest. So this person was playing badminton with him in the MIG club when he collapsed. The MIG club didn't have an AED. So he started massage, got an AED from his own building and revived him. And this person in his own building, in the morning walk, had a cardiac arrest, who was revived. But these were all, the best, one of the best stories, apart from the first one of Samir Farishta. I'll share with you 2 very wonderful stories. Marine Lines railway station, AED was installed a couple of months ago and the railway staff were trained in chest compressions. And within 2 weeks of doing this by Dr. Akshay Mehta and his Rotary group, 2 railway staffers, including this gentleman, found somebody collapsed, recognized cardiac arrest, started cardiac compressions. Someone ran and got the defibrillator from the station master's cabin. They shocked him. Twice they shocked him. They revived him. Then he was taken to the close by hospital, found to have a ACS and survived. So can you imagine a railway staffer without a doctor, without a paramedic saving somebody? It was unheard of. It was unheard of in Mumbai. Thousands of people must have died in trains and in the railway platforms, And in fact, one of my patients who had a cardiac arrest when he was in USA, there somebody revived him. He said, "Mi Thaneyat asto." If I was in Thana, people would have said, "Darudia padlay rastevar." People, drunkard is lying on the road. But so things can change. This was an Indian girl in UAE was revived. This is a policeman. So there's a policeman who saved somebody in Lucknow by prompt chest compression. Ahmedabad, policeman has saved someone. So we are seeing more and more success stories of people who have been saved out of hospital. And I think we need to teach at least 20% of the population about cardiac arrest, because if there's 20% of the adult population knows about it, then there's a good chance in India that somebody around 1% at least will know about it and will take the lead, and we have to reach that threshold. This video, Dr. Vinod Singla is one of our colleagues in Hissar who had trained his society, his big colony and in his area in cardiac arrest. Sorry. And this is another story from a lady who was living in his society, and it's a short clip which I'd like to share with you. Yeah.
मैं संगीता ग्रीन पार्क से मैं कुछ दिन पहले वॉक कर रही थी। वॉक करते हुए मैं गिर गई थी, तो मेरे कुछ फ्रेंड्स मेरे साथ थी जो वॉक कर रही थी। उन्होंने मेरी छाती दबाई, सीपीआर किया, और उसके बाद डॉक्टर विनोद सिंगला जो हमारे ग्रीन पार्क में ही रहते हैं, तो उन्होंने भी हमारा सीपीआर किया, मेरी छाती दबाई, और वो नेक्स्ट डे मुझे हॉस्पिटल लेके गए। और नेक्स्ट डे मुझे उस टाइम मुझे हॉस्पिटल लेके गए और नेक्स्ट डे मुझे होश आया। तो ये 2 महीने पहले हमारे ग्रीन पार्क में कैंप भी लगा हुआ था जो डॉक्टर विनोद सिंगला ने ही लगाया था। उन्होंने सीपीआर सबको सिखाया था, उसी की वजह से मैं बच पाई। तो मैं यही चाहती हूँ कि सभी लोग सीपीआर सीखें, उसका फायदा उठाएं, ताकि आप लोगों को भी भगवान ना करे किसी को कोई ऐसी दिक्कत आती है तो अपना सेफ्टी अपने आप से कुछ तो हम कर पाए। धन्यवाद। मैं
So then we thought, every year let's have a cardiac arrest awareness week, and this started in 2021 as COVID, when we were still in the COVID era, and several cities participated in this cardiac arrest awareness week. So we repeated it in 22, a second cardiac arrest awareness week in September, October, where we had 2.5 million online views. The awareness week 3 in 23, where Ajay Devgan helped us a lot in popularizing it. Many more cities participated. And recently, a couple of months ago, we had the awareness week 4, where the actress Kajol helped us in, and a lot of our doctor colleagues in different parts of the country took this movement forward. Now we have created an app with the help of some funding, but this app is free. This app will not only tell you about cardiac arrest, tell you about how to give chest compression, but also in some cities, and this app will keep getting upgraded continuously, tell you where are your close by AEDs. And hopefully in future it will also alert the volunteer trainers in your area. This is free. There will be free upgrades. So please encourage people to download it. Both on Android as well as on Apple, it is downloadable. And this is the contact details which you can share for anyone who wants to learn CPR either online or in person, at least in Mumbai and in other cities. We can direct them for the same. So I'll end here by saying that the government, at some stage, this has to be a program taken by the government at some stage. But we can't wait for that stage. And I think they have a lot of other health priorities. But if we at least show, and now the next step will be to find out how many lives have been saved, how much cost effective, how much it is. But if this effort grows, then I'm sure we are moving in the right direction. Thank you.
Thank you, sir. Thank you.
Dr. Yash, just want to tell you that we are invited tomorrow to meet Mr. Nadda, the Health Minister of India. He is in Ahmedabad tomorrow. And Ahmedabad Physician Association was invited with dialogue with him. There is many associations invited to have some transparative ideas and views, and they want to take the healthcare to next level. So they invited all of our association's office bearer to give some idea. We will definitely take this point personally to.
I think what you should impress on him is to make it compulsory in schools and colleges. Before somebody passes out from class 10, class 12 and graduation,
Yes.
there should be a couple of lectures on cardiac arrest, and there should be at least a 5-mark question, because what works in India is if there is a question, they will study it.
If possible, we will.
It doesn't cost the government anything to implement this in the syllabus.
Yes. And if time permits and if we get time, we will take time to meet him somewhere else or in detail also. Thank you.
Thank you.
So what question from here?
Incidence of sudden death increasing in younger generation. What is your take on it?
I think there is no doubt. There is no doubt. I think all the cardiologists here also would probably agree with me that vascular events, whether they are cardiac, venous vascular events, you talk to the radiologists, or cerebrovascular events, have definitely increased in the post-COVID era, especially amongst the younger generation. I don't have hard data from India. There must be. I'm not aware of it, but this is the observation of mine at least, and many of my colleagues.
Cardiology, can you just
I think
extrapolate?
there's more thrombogenicity, I think.
So,
And-
sir, is it that we are reporting more cases, or we are seeing more cases, or is it post-COVID, or it is because more marathons are being, you hear lot more
I'm
about
not talking
that.
of sudden death. I'm talking of vascular events.
Okay, yeah, sudden death, it could be any of these three, or do you think, because
Sudden death
suddenly we are seeing
see,
lots more.
marathoners, sudden death is a very, very minority. Majority would
Almost every other marathon has one person.
be.
with
India has the
Is it because
highest
fluid electrolyte imbalance
to
leading to
the
VT or something?
numerator-denominator ratio of the number of people running marathons versus numerator being the sudden death. India is highest.
So my question is related to
I
that.
think in marathon, there should be all along the marathon route, there should be at particular points volunteers available who can know how to resuscitate and defibrillators available.
So my question is related to that. You showed that 2.8 times more deaths in athletes than non-athletes. And so the incidences that we hear are mostly for non-professional athletes who are doing either hobby sport or running marathons and cyclothons and all that. Not the ones who are playing professional sport. And sir, as doctors, we are the community who has, encouraged this exercise fad going into the public. So what possibly do you think is the reason for this?
Exercise is good. It's a bell-shaped curve. No exercise has the highest morbidity and mortality. Moderate exercise, you're better and better and better till you reach a peak. More than moderate exercise, you plateau and then start going. Severe exercise, start going down the bell-shaped curve. So moderate exercise is definitely good. Moderate exercise means even 5 days a week, if you walk for 1 hour, is good enough. The problem is, and I had given this all the risk factors in one sentence when I had spoken in one of the American Heart Association meetings. A middle-aged obese man, a smoking middle-aged obese man, hypertensive, goes for an unaccustomed vigorous jog on a cold winter Monday morning. So remember, these are all risk factors. So unaccustomed exercise, especially in a cold environment, especially suddenly, you're not doing anything. Now suddenly you decide to play a badminton tournament because you had played 5 years ago, you're at risk. So whatever exercise you do it sensibly.
Because sir, in your examples also somebody was playing tennis, somebody was out for a walk, somebody was, doing some form of exercise when they
Not
dropped
necessarily.
unconscious.
Couple of those.
Two or
yes.
three examples were like that.
Yes. So unaccustomed exercise and vigorous exercise is bad, but sensible exercise is definitely good. No, I will tell you, if you take details of this gym, this gym trainer is a big fad in Bombay. I don't know how it is in Ahmedabad. And majority of the trainers, even of the celebrities, are Anguta Chap. I always asked, has your trainer ever heard of Krebs cycle? I'm sure they have not. They pump artificial proteins. They give all whey proteins, bottle proteins. There was one gym trainer who was even given amphetamine. Means what one is doing, the other will do. They make people go out of, they push you for what? You know, they make you, those barbells and all when they were doing, people have collapsed. So, sensible amongst those who collapse in the gym, majority of them have not been doing sensible exercise and have been taking all these funny things. And the worst part is, they are not CPR enabled also. In one gym, in our whole health club, I'm sorry to say, they were making him smell the chappals when the person collapsed.
And so that incremental weight training and all that is also there. I think there's
This
a capacity for
high
a person
intensity
to have a certain
training,
weight.
intermittent fasting, or see all this it's a big, very popular among youngsters. It has some benefits, but the risks and the disadvantages outweigh the benefits. You can't keep up that type of lifestyle. So it's better to adopt something which is moderate and which you can maintain for several years.
Thank you, sir.
Would there be any difference?
Wants to go for some high intensity training or gym, do you recommend regular cardiac workup, particularly to rule out HOCM and long QTC?
See, those who are taking competitive athletics or competitive sport, they are now in many countries mandated to rule out underlying heart disease by simple ECG and echo if you're really being competitive. So that makes sense. But for everybody who's going to gym, that is not really required. More important is be sensible.
Is it commoner in isotonic exercises than aerobic, or you haven't noticed that difference?
No, it is more in the isometric exercises, especially the heavy weight training.
They keep on increasing the weight in 2 years. They reduce the weight in 2 years. How do you explain that? And what is the effect on the body?
No, there's, I don't know how popular it is, but now this semaglutide and this new one, the Ozempic, we have the tablets, and now the Monjaro,
Right.
they have become extremely popular in amongst the younger generation, especially among these celebrities. And sometimes they are forced to do it for their profession. Obviously, it's not good. I mean, these going up and coming up.
Tirzepatide,
It works. It works. It works in reducing weight. Dramatically works. But
that has
I
come
don't
now.
know.
That has just recently come. In
Which
the
one?
Market, like, but this has been happening for years together.
Yeah, that's true. That's true. As on the lighter side, one of the talks on this inclisiran. So in Sion Hospital, the medical rep had come. So the cardiac surgeon told him, you are at the wrong place. I mean, if you give inclisiran to my Sion Hospital patient, definitely his cholesterol come down because he won't have money to eat only after that.
So, few months ago, there was some camp in the Bangalore hospital. Okay, they have screened around 200, 2000 ECG in a day. It's a primary prevention. Do you suggest screening of ECG in all the population?
No,
This is
no,
marketing.
no. See, ECG is simple and inexpensive tool. As Ponde said, with artificial intelligence, definitely. See, you're using the simple ECG of 100 years ago because it's so easily done and you have such a vast database. So it can tell you, especially those who are running a marathon and all, definitely that ECG screened by AI is a good idea. You can't do echoes for everybody, but it'll tell you who is at risk.
But that was for general population. They want to screen all the population for ECG to assess
The-
congenital syndrome or QT syndrome or
To
something.
prevent sudden death, it's not going to, I doubt whether, because the just one single ECG to prevent sudden death may not be it won't really make much of an impact.
So not for the prevention.
In a routine clinical checkup, do we need to tell this patient that?
See, I never look at that computer interpretation of the QT. So I always look at the QT myself first, and then if it looks, then that's quite accurate. So sometimes, again, as Ponde said, it depends on good data. See, there's a typical this thing in computing: garbage in, garbage out. In India, half the ECG machines only are rubbish. Half the stress test machines only are rubbish, especially where you see that linked median. So what artificial intelligence will do with that such data? But QT interval, so therefore at faster heart rates, it's often will show you long QT because it doesn't adapt so fast. If the QT is more than half of the RR interval, look at it more closely. That will be the rule of thumb.
Cause of sudden death, like cardiac death is sudden death.
See, sudden death is more or less synonymous with sudden cardiac death. There are very other few causes where you will collapse suddenly and die. Yes, there are. For example, suddenly a massive brain aneurysm rupture, a sudden aortic rupture, sudden massive GI bleed. But they will account for together less than 10% of all sudden deaths. So 90% of sudden deaths are sudden cardiac deaths.